Yasser Rifay, treatment of high myopia by PRK without mitomycin.
Hello everybody, so I'm very glad to be here and thank you for invitation for this very beautiful meeting. So I try to speak in English. My presentation is about PRK in high myopia. I have no financial interest in this presentation. So PRK is a photorefractive keratectomy, it's a surface ablation. It's the first technique, laser technique. It starts in the 70s, and it is commonly used in the low and moderate myopia. So the biggest complication of PRK is the haze. But there is an advantage is the cornea stability, so we will not cut the cornea, and there is very low risk of ectasia. So I did a small study about 127 eyes, which was enrolled between 2019 and June 2021. So the mean age was 30. So 29 cases was operated unilaterally and 48 bilaterally. So the patient selection is as all refractive surgeries. And why I choose the PRK in these cases? Because my first technique in high myopia and astigmatism is phakic IOL. So the main reason was the contraindication of phakic IOL, narrow chamber or other or narrow angle, or there are some cases of patients that refused an implantation. And the result, so all patients were operated by the same surgeon. I used the TENU. The breathing of epithelium was being manually. So the minimal refraction treated was -4, -2. So the calculation of the myopia is by the not the spherical equivalence, but it's the addition of the myopia and the astigmatism. So it determined the ablation depth, and the maximum refraction was -7 with -4, 27, 75 cylinder. This is an example of a treatment. So the optical zone was a little bit small, 6 to 6.3. It was adapted to mesopic people. I used the echo mode, it's a special mode in this machine, in 25 eyes, and the estimated postoperative keratometry was more than 35 to avoid the hyperflattening of the cornea, and the estimated postoperative total corneal thickness was more than 4 microns, it means with the epithelium. So the ablation depth was between 66 microns, and the biggest one was 112. No mitomycin was used because there was a period of time that there is no mitomycin in Morocco, so I treated my patients without mitomycin. The post-op treatment, I used the steroids for 2 months, digressive way. Non-steroid dropped for 2 days to avoid the pain and the inflammation. And antibiotics for 10 days, vitamin C for 1 month. Bandage contact lenses was used for 5 days, except 5 cases with the delayed healing. The follow-up, I see the patient the first day, the third day, the 5th day to remove the contact lens, and the final visual acuity was evaluated at 3 months and follow up every 6 months. So the result was good. So I have all patients were count finger before surgery, and the mean postoperative was 0.8, and there are 3 cases of haze, 2 cases of moderate haze, and 1 case of really complication. It wasn't a haze, but it was this corneal dystrophy discovered perioperatively. 5 cases of delayed healing, but it was managed with contact lens and lubricants. So there are some studies shows that a lot of studies that show that there are risk of ectasia with cutting the cornea, LASIK or SMILE. And with PRK, we have low risk of ectasia, and the haze prevention can be done by mitomycin, but even without using it, we didn't have a lot of cases of haze. And the outcome of the vision after PRK in a lot of studies is the same as LASIK. So that's why I choose this technique to treat this kind of patients. So my first technique I choose is phakic IOL, but if I cannot, I do PRK. And thank you.
Thank you. Next one will be Arya Markovic, scleral fixation of IOL using flanges.